Spondyloarthritis. Today we discuss spondyloarthritis. A common feature between spondylitis and seronegative arthritis is that they affect a specific anatomic structure, the enthesis, as a very first pathogenic event. Here the inflammation that localizes at the site where tendons attach to the bone or to the articular capsule. The structure is quite important because it allows the distribution of the mechanical load, and it is extremely important for our ability to bend our limbs. The involved macroscopic structure is basically made of connective tissue. There are two main patterns of enthesis: fibrous enthesis and fibrocartilaginous enthesis. Generally speaking, fibrous enthesis are those in which the tendon directly connects to the bone. The quality is not very high. It is composed of fibrous tissue. These specific entheses are very seldom involved in rheumatologic disorders. Those that are most important for spondyloarthritis are fibrocartilaginous entheses. Here the structure is slightly more complicated, meaning that we have not only fibrous tissue in the bone but also the cartilage in between. We have cartilage that is uncalcified and cartilage that is calcified. So we have this wall tissue basically that are all involved in making the connection between the tendon and the structure to which the tendon is linked. This is the Achilles tendon left on the bone. This is the overall structure of the tendon. Please notice that there is no sharp boundary between tendons and bones. So it's extremely important because it allows the dilution of the stress force along both the structures. The people with a greater risk of breaking tendons and ligaments in general are weightlifters and athletes because they overuse this structure. However, for athletes or people who have to deal with heavy loads for occupational reasons, the main issue is related to the fact that initially the enthesis sort of breaks, causing an enthesopathy. The enthesopathy is troublesome because entheses are not easy to heal. The presence of the fibrocartilaginous tissue at an enthesis stiffens the tendon ligament and thus helps to create a more gradual change in mechanical properties between soft and hard tissues. It ensures that any bending of the tendon ligament fibers during joint movements is spread gently away from the bone, thus dissipating stress concentration. All fibrocartilages associated with normal entheses are avascular. This contributes to a poor healing response at and near attachment sites. The avascularity reflects the mechanical conditions to which the tissues are subject, notably compression. It is completely different for enthesitis because enthesitis is related to the primary event of the structure getting inflamed. It gets infiltrated by leukocytes that start producing inflammatory factors such as cytokines, which attract other leukocytes, causing inflammation and erosion of the bone. The bone in turn activates a hyperproliferative hyperplastic response. Since the inflammation is caused by an autoimmune attack against the molecular structure of the enthesis, you often have, but not always, a systemic involvement. Pain and inflammation are diffused. These are the main places that are usually involved in these kinds of diseases, like the eyes in 40% of cases, neck in 75% of cases, rib, spine junction 70% of cases, lumbosacral 50%, sacroiliac 100%, and then others. Also the eyes, yeah, said Joe and others. The initial event that is inflammation with destruction of the initial event is inflammation with destruction of the tendons, and the response of the bone is resorption. The X-ray image over here shows a typical event in the early phase of this kind of inflammatory response. The disease is slowly progressing and it often takes quite a long time to go from inflammation to erosion and from erosion to tissue damage to proliferation and sclerosis. We have the steps from mild inflammation to moderate inflammation to severe inflammation. In the mild inflammation, cell infiltrating the connective tissue at the junction of the bone and the annulus fibrosus. Moderate inflammation, progression of the inflammatory tissue in the bone outside of the cartilage and plate. and severe inflammation, involvement of the connective tissue as well as the bone on both sides of the cartilage and plate. In the phase of mild inflammation, the structures get infiltrated and the bone and cartilage may remind you of the synovial pannus we spoke about in rheumatoid arthritis. It is inflammatory even if it's not organized or vascularized. As the disease progresses, inflammatory cells infiltrate more and more at the enthesic site. The more the enthesitis is eroded, the more the bone activates a proliferative response carried out by chondrocytes and by osteoblasts. This pattern is particularly important also in ankylosing spondylitis, which is an atypical spondylitis. To sum up, the three pathogenic steps are inflammation, erosion, and proliferation. The image here on the right shows the pathology of enthesis in ankylosing spondylitis. Normal, inflammation with TNF, erosion by cathepsin K and matrix metalloproteinase 1, and syndesmophyte formation with BMP pathway and Wnt pathway. Spondyloarthropathies are a family of diseases comprising ankylosing spondylitis and other conditions such as psoriatic arthritis. They have some common features such as the involvement of enthesis, the slight male predominance, and the association with the allele HLA-B27. We'll start discussing ankylosing spondylitis. It's a chronic multisystem inflammatory disorder involving primarily the sacroiliac joints and the axial skeleton. It's an autoimmune disease directed against articular enthesis and secondarily synovial structures, connective tissue antigens in general, like aorta, respiratory tract, and uvea. The main risk factors are gastrointestinal or genitourinary infection, HLA-B27, and male sex. The shared clinical pathological features are bone erosion, which leads to production, and ankylosis. Typical involvement of the spine, extraaxial arthritis is usually asymmetric, severe reduction of joint mobility, and extraarticular manifestations. The prevalence is 0.1 to 2% of the general population, with higher in Northern European countries and lower in people of Afro-Caribbean descent. Ankylosing spondylitis usually is not diagnosed early because usually the onset is very slow, almost never abrupt. It starts with low back pain. Low back pain is a common condition and usually do not look for medical attention because of it. It's usually due to bulging discs or muscle weakness, and you would expect it in old patients because of the wear and tear effect. However, this specific low back pain has some particular features. Typically, the onset of ankylosing spondylitis is in people younger than 40 years old. Young people. There is the onset of a relapsing remitting low back pain. Usually, you need at least 3 months of back pain to classify it as inflammatory back pain. So at least 3 months are needed. Usually people younger than 40 years old. Relapsing remitting pattern. Typically, it's not relieved by rest. The mechanical low back pain of older patients usually fades if they lay down. This is not the case for inflammatory back pain. If you stop or stay still or lay down, the symptoms worsen, whereas if you move, the pain improves. This is possibly the most typical sign. The patients complain of the fact that they cannot stay still. These are all features that can help the physician look for a more complex diagnosis rather than just mechanical low back pain. Generally speaking, in most of these patients, the diagnosis is delayed because doctors think there may be something wrong with the spine. In the MRI, they do not find anything in particular, just the synovium will disappear. And again, once it starts, it does not disappear but keeps bothering the patient more and more. In the early stages, you do not see any important changes in the spinal MRI. If you are suspecting an ankylosing spondylitis, you should take an MRI of the sacroiliac joint, where you can see some small changes even in the early stages. If you are looking for disc bulging, you are not going to find them. In fact, patients with mild disease may remain undiagnosed. The most commonly involved structure is the enthesis. Nevertheless, consider that the connective tissue making the enthesis is very similar to the connective tissue that you find at the level of the sacroiliac joint. Sacroiliac joints are not very movable joints. You possibly move them during the delivery of a baby. However, they can get inflamed. and it is the specific event in leading to the inflammatory low back pain we were discussing before. At the very beginning, low back pain that is related to sacroiliitis is asymmetric. It starts on one side, then usually it will appear on the other side. This pattern can go on for a few months. Usually, after a while, it gets worse and the patient seeks medical attention when there is bilateral involvement of the hip. The pictures on the right show the area that is affected in sacroiliitis related low back pain. You do not need to specifically localize the pain. Just remember that it never irradiates below the knee. If the pain radiates down to the foot, the sciatic nerve is involved. The sacroiliac joints connect the spine to the pelvis and lower skeleton. These joints provide minimal movement, approximately 2 to 4 millimeters, with weight-bearing activity unlike that of the hip or knee. The most common symptoms of sacroiliitis include some combination of fever, pain, usually low back pain, leg pain, maybe in the front of the thigh, hip pain and/or buttock pain. Pain that is worse when sitting for a long time and worse when rolling over in bed. Stiffness felt in the hips and low back, especially after getting out of bed in the morning or after sitting still for a prolonged period. Asymmetric or unilateral at the beginning, at later stages of the disease, inflammatory involvement is almost invariably bilateral and symmetric in distribution. Anyway, an inflammatory low back pain is a small fraction of the low back pain. You should consider it just when the patient has some specific epidemiological characteristics. Young males with low back pain who is not a weightlifter. Ask the patient about the kinds of pain he is complaining about and whether it is either relieved by rest or not. Try to find out if there might be another medical condition causing the pain. The picture on the right shows some maneuvers you can perform during the physical examination of some patients. Okay. To sum up, at the very beginning you find this asymmetric, relapsing, remitting pain that is related mostly to the inflammation of the joints. Later on, however, there will be destruction of the tissue with the proliferative response of the bone, which in the long run will lead to ankylosis and loss of mobility. You should recognize patients with spondylitis and treat them before they become completely ossified, but you should also avoid overdiagnosis. The joint remodeling stages are inflammation of the subchondral bone, osteitis, subchondral bone erosion, which leads to initial increase in joint space, a reactive sclerosis with osteophytosis and syndesmophytosis, so capsule ossification and cartilage reabsorption, and then ankylosis, loss of joint mobility. At first, there is inflammation, and then the disease progresses to calcification of the periarticular structures, which can get pretty nasty. In the image on the right, you can see sacroiliac joints that are perfectly healthy joints. However, this was a patient with low back pain, and this is what happens when you perform an MRI of the same patient. You can see that indeed you have a clear signal of the left iliac left joint. Even though the X-ray is cheaper and may be useful in some cases, it's not very sensitive because bone remodeling occurs long after the inflammatory process started. On the other hand, the MRI can detect inflammation and can be used to diagnose this disease much earlier. The very first change in the very first phases is a phenomenon called pseudo-widening of the joint, which is related to bone erosion. This pattern is called rosary beads because normal and wider portions of the joint are alternating in a sort of necklace effect. The CT scan on the left is taken from the same patient. However, consider that generally speaking, MRI is more sensitive. In the long run, the low back pain paradoxically may get better because the joint is completely obliterated and the inflammation cannot occur anymore. It would not be a big deal if the sacroiliac joint was the only one affected. It's not very mobile, maybe it may be healthy or not. Unfortunately, other bones get affected by osteoitis. Spondylitis usually starts with sacroiliitis, but most patients also have involvement of the spine with the same sequence of events: inflammation, erosion, and hyperproduction. In the spine, the early stages of spondylitis are manifested as small erosions at the corners of the vertebral bodies. The areas are surrounded by reactive sclerosis and have been termed the shiny corner sign or Romanus sign. Consider that since you erode the corners of the vertebrae, the whole shape of the vertebrae changes. If you look at this projection of the colon, second picture on the right, you see it looks pretty much like a square. Squaring of the vertebral body is another characteristic feature of ankylosing spondylitis. It is caused by a combination of corneal erosions and periosteal new bone formation along the anterior aspect of the vertebral body. This is best seen in the lumbar spine, in which the anterior cortex of the vertebral body normally is concave. Again, the other effect that contributes to the fact it is a square is you have erosion on the corners and you have a reactive sclerosis to sort of compensate the loss of bone, making new bones which is going to distribute along the anterior aspect of the vertebral bodies. So we have a progressive change in the shape of each single vertebra. This is particularly clear if you look at the lumbar spine. Picture on the left is a frontal radiograph showing T12L2 lateral syndesmophytes and interspinous ligament ossification extending from T12 to L1 and L2 to L4. It might be not very as clear if you look at the dorsal cerebellar spine. You see that an ossification of the interosseous ligaments on both sides. You see there is still an empty space, but it is going to get completely ossified. The formation of syndesmophytes, which is again a rather late event in the natural history of the disease, is pretty typical of spondylitis and ankylosing spondylitis. If you see this kind of result, you can say they have got spondylitis. The images on the right, on the other hand, show something different. The ossification here is not following the interosseous ligaments, but is more horizontal. This is an osteophyte and this is related to osteoarthritis of the spine. Osteophytes form because of the increase in a damaged joint surface area. This is most common from the onset of arthritis. Osteophytes usually limit joint pain movement and typically cause pain. They form naturally on the back of the spine as a person ages and are a sign of degeneration of the spine. Okay. This is a completely normal event in older patients, but if you look at it, you see the pattern is pretty much different. The general idea is it is supposed to widen the surface on which the mechanical load is placed. It enhances the stability of your spine, but it is not related to the ossification of ligaments. It's not always as easy in real life, but it's not a complicated differential diagnosis for radiologists or anybody who will look at the picture. Anyway, in ankylosing spondylitis, we usually don't find osteophytes. This, on the right, is what the spine of a patient with long-lasting spondylitis usually looks like. It's called the bamboo spine because at this point there is complete ossification of the space between the vertebral bodies. The spine is not very flexible. The typical appearance of this patient is called a question mark posture, which is related to the fact that you lose the normal lordosis but instead get an exaggerated kyphosis. You get frozen in a specific position. Here is the typical semiotic position for you to know about spondylitis. Please consider this is something that is particularly important when we did not have radiological tools. This will help you to understand if a patient has spondylitis much before they get so stiff to be bent. So, here you see the evolution, the demonstration of fixed flexion deformity, Lordosis obliterates. Normally, here we have exaggerated lordosis when flexion of the hip. We have lordosis obliterated and flexion of extremity is revealed. This is a typical feature of the patient who has been followed from 47 to 73. If you get spondylitis, you will not be able to retroflex the head to touch the wall, which is the occiput to wall test. The patient stands with heels and buttocks against the wall. The head is placed back as far as possible, keeping the chin horizontal. More sensitive test is the Schreiber test. If you have a bamboo spine, you will have a lot of trouble in bending your back. This test rates the flexibility of the lumbar spine. A mark is made at the midpoint between the posterior superior iliac spine at around 10 centimeters above. The distance should reach up to 15 centimeters when the patient is asked to touch his or her toes without flexing the knee joints. Please also consider that these patients may have peripheral arthritis, which occurs in about a third of patients. Joint involvement is usually asymmetric, involving the hips, shoulder girdle, glenohumeral, acromioclavicular, and sternoclavicular joints, the joints of the chest wall, crossovertebral joints, costosternal junction, and symphysis pubis. Other peripheral joints are less often and less severely affected, usually as asymmetrical oligoarthritis. In children, ankylosing spondylitis tends to commence with arthritis prior to spinal disease developing. Temporomandibular joints are occasionally involved. This applies to more or less one-third of the patients. You can either have something related to the hips, generally speaking to the girdles, or you have a monoarthritis or asymmetric arthritis. Children, on the other hand, may have asymmetric acute monoarthritis occurring much earlier than sacroiliitis. Rheumatologists should remember is that if it should remember that if a kid has a swollen knee, it may also be the onset of spondylitis. As we said, the pain related to sacroiliitis can be associated to inflammation of the spine, peripheral arthritis, and enthesitis. Consider that inflammation of the enthesis, which is again fairly common, is going to be painful, and the pain is related to these specific sites that we find in this cartoon. So here, the one we saw before. Extraarticular manifestations may occur. There is a strong association with gut involvement. Ileocecal inflammation occurs in 50% of patients. There is a close relationship with IBD. There is an increased risk of developing IBDs, and there are some Crohn's-like immunopathological features. Also, the presence of IBDs is a risk factor for the development of severe hip arthritis. A lot of inflammatory events might occur in the eye. We have acute anterior uveitis, which occurs in 20-30% of patients. Of all patients presenting with acute anterior uveitis, a third to a half have or will develop ankylosing spondylitis. It presents with an acutely painful red eye and severe photophobia and requires emergency treatment. There is a good response to therapy, but there are some complications if untreated. Can have anterior synechia in the iris and cornea, posterior synechia in the iris or lens, and cataract with cystoid macular edema and glaucoma. It's not difficult to diagnose because the patient gets one red painful eye. Remember, uveitis often occurs together with spondylitis. Heart involvement is pretty specific. There is inflammation of the first part of the ascending aorta, aortitis, possibly because some connective tissue constituents are shared among the enthesis, the eye, or specific sections of the aorta. Spondylitis quite often leads to a mechanical distortion of the ring of the aortic valve, causing aortic regurgitation, which can be quite severe. So beware. There is no inflammation of the aortic valve itself. It's just a consequence of inflammation of the ascending aorta. Because of the inflammation of the heart, a fibrous scar may form, causing various degrees of atrioventricular block. and arrhythmic disorders. If you have a patient with arrhythmia and spondylitis, you should make the diagnosis. Please, when you consider the therapy of ankylosing spondylitis, take into account the degree of heart involvement. Regarding the lungs, we have restrictive lung diseases, which may occur in later stages, with costovertebral and costosternal involvement limiting chest expansion. The lungs themselves are healthy at first, but in the long run, patients may develop pulmonary fibrosis of the upper lobes. Renal involvement, amyloidosis, is a very rare complication in patients with severe active and long-standing disease, which may cause renal dysfunction with proteinuria and renal insufficiency or failure. We have also association with IgA nephropathy. We have also neurological involvement, typically usually occurs secondary to fractures of a fused spine. Also, patients with uh, ankylosing spondylitis are prone to atlantoaxial subluxation, which may lead to cervical myelopathy. Caudequina syndrome may occur in patients with severe long-standing disease. Caudequina clinical features are saddle anesthesia, sphincter erectile disturbances, and motor deficits. Of course, you should remember that since the spine is so rigid and stiff, the chance to break is much higher, so there are a lot of complications that mostly derive from the fact that you get myelopathies related to this particular feature of the disease. The modified New York criteria are used to classify ankylosing spondylitis. The clinical criteria are low back pain for more than 3 months improved by exercise, not relieved by rest, limitation of lumbar spine motion in both the sagittal and frontal planes, and limitation of chest expansion relative to the normal values for age and sex. Radiological criterion is sacroiliitis on X-ray. Definite ankylosing spondylitis is diagnosed if the radiological criterion is present plus at least one clinical criterion, and probable ankylosing spondylitis if three clinical criteria are present, or if the radiological criterion is present but no clinical criteria are present. Criteria are pretty old. This is the reason why they do not even take into account MRI, and they do not take into account the HLA-B27 positivity. They are just useful to remind you students which are the main clinical features that differentiate spondylitis from the rest of the stories. About the HLA-B27, ankylosing spondylitis has a strong genetic predisposition linked to HLA-B27 and other genes we are discovering nowadays, such as ARAP1, which is endoplasmic reticulum, aminopeptidase 1, which is active in endoplasmic reticulum involved in protein processing and transport. Some aminopeptidase, an enzyme that cleaves other proteins into smaller fragments. It has major functions in the immune system, like in cytokine receptors and MSC complex presentation. So we must be very cautious, because if there are 100 people who are HLA-B27 positive, you have 98 to 99%, you have 98 to 90 or 99% that are not developing ankylosing spondylitis. So only 1 to 2% of those which are HLA-B27 positive are at risk to develop ankylosing spondylitis. 15-20% risk if first degree relative is affected. So HLA-B27 increases substantially the risk, but it is not sufficient to cause the disease, and you cannot use it to diagnose the disease. The relative risk of developing ankylosing spondylitis is roughly 87%. It's not difficult to find patients with ankylosing spondylitis and who are HLA-B27 negative, so the 90% may be lower than the actual reality. Around 30-50% of the patients are HLA-B27 positive, and considering that in the general population, HLA-B27 subjects are 1-2%, it means that in fact, to express the specific HLA molecule is indeed a risk factor. How would you study this? There are some hypotheses trying to explain the association between ankylosing spondylitis and HLA-B27. Scientists tried to put HLA-B27 in rats and they develop arthritis and enthesitis. They do develop oncopathies, nail pathology too. We see many studies using transgenic rats, but not mice, because mice do not develop anything. The other interesting issue is the fact that if you breed these transgenic rats in extra clean animal facilities like in germ-free animal facilities, they do not develop any kind of ankylosing spondylitis. This might get more interesting when we speak about reactive arthritis, which again is related to ankylosing spondylitis, but it is triggered by an infection. There are missing pieces to the puzzle. Question. Okay, there are at least three questions that are completely open. Why does HLA-B27 facilitate the disease? What is the role of microbes? Why is there selective involvement of enthesis? Some hypotheses say that B27 is a rather complex molecule. It is polymorphic like most of our MSC1 molecules. It is true that the HLA-B27 is associated with spondylitis, but not all of the molecules belonging to that family are associated to the disease. For example, if the AO2 is the original molecule that is associated with the disease, there are other subtypes of HLA-B27 that do not confer any specific risk of developing spondylitis. There is a polymorphism that leads to an amino acid mutation in the binding groove of the B27. There is an aspartic acid in the HLA-B2705, which, as you remember, is a charged amino acid which becomes histidine in the HLA-B2709, which is not associated with the disease. There have been quite a lot of studies done by physicists who try to understand how does a change in the binding groove of the molecule of this molecule was related to the pattern of peptides that can be bound and presented. So later to this hypothesis of cryptogenic peptides that were sort of trying to take into account most of the questions we discussed before. One hypothesis is that there are some peptides that are expressed by the microbes that are involved in reactive arthritis, such as chlamydia, shigella, mycoplasma, and salmonella, that could be presented by the HLA-B27 and could lead to the clonal expansion of anti-salmonella or anti-chlamydia T cells, which, however, would cross-react with some molecules present in the enthesis. This is not completely convincing, because actually you do find this kind of T cells both in patients with spondylitis and in patients without. So the fact of having HLA-B27 T cells recognizing epitopes of intracellular microbes per se is not associated with the disease at all. There are a lot of possibly autoreactive T cells circulating in our bodies, but we are not getting spondylitis. Moreover, you can transfer the disease using bone marrow-derived cells from a rat to another healthy rat, but you cannot transfer it perfectly by depleting your cell population of MSC1 recognizing CD8 positive T cells, while you can transfer the experimental spondylitis using CD4 positive T cells, which are supposed to recognize epitopes associated to MSC2. So people got back to studying HLA-B27 in particular because it tends to lose easily the beta-2 microglobulin. Remember that MSC1 is composed of heavy chain and this variant short chain, which is the microglobulin. It is important to make a stable complex with the peptide that is inserted in the groove. Now, compared to all of the other MSC1 molecules, HLA-B27 can lose much more easily beta-2 microglobulins, so you have monomers of healthy chain that remain and are typically unfolded. They have also found in some cases these monomers can homodimerize and can form fake MSC2 molecules. If you remember, MSC2 molecules are dimers, and these HLA-B27 dimers can also apparently bind to peptides and present them to CD4 positive T cells. This is another hypothesis that people are doing, but the point is that B27 per se is presenting an area of peptides, but the actual relevant event is that they get misfolded because of the fact they get rid of beta-2 microglobulin. Another important issue is that possibly because of the fact that overall structure is so unstable, you you easily get unfolded protein response, which is related to the fact that there is stress related to the processing of all these unfolded HLA-B27 molecules, which must be recycled. If you have an unfolded protein response in antigen-presenting cells, and this is going to facilitate the production of cytokines, which might be associated to a preferential primer or priming of Th17 cells, which might be involved in the pathogenesis of the disease. The supporting information is the fact that IL-23 receptor is identified as a further susceptibility locus, which is involved in the genetic risk of developing spondylitis and is associated with B27. If you have the correct B27 and a specific polymorphism of the IL-23 receptor, your risk of developing spondylitis is substantially higher. So this might be something to consider. Finally, we were discussing before the possible role of aminopeptides, which is ERAP1. And again, it's not completely easy to understand what is the actual function of when the main idea is that if you make a specific set of peptides that depend on the function of specific living enzymes, you might get HLA-B27, which might be more stable or less stable, or possibly give more or less UPR. And so these things we are speaking about might be connected. Finally, why entheses are actually involved in the inflammation. There is unfolded protein response, it activates Th17 cells and CD4 positive T cells, and they make an inflammatory reaction. But why is this inflammatory reaction specifically associated with entheses? People have tried basically to propose that there are bacteria, Chlamydia and Salmonella, that do arrive to the entheses and find their a specific niche in which they can survive and proliferate. So at this point, our immune system is going to find them and try to get rid of them, and they get rid of the entheses as well. However, there is not a single molecular trace in the body of this theory. Another possibility is that we have macrophages that get infected and then, for some reason, like to go into the entheses and stay there, and they would activate the response, or possibly there is some cross-reaction that is related to some sort of modification of the regional cryptogenic peptide hypothesis that would somehow focus the inflammatory potential against these structures. The SKG-ZAP70W163C mutation of the bulb C mouse strain alters the sensitivity of developing thymocytes to negative and positive selection, enriching the peripheral repertoire with IL-17 skewed autoreactivity cells. Beta-glucan is a major component of bacterial and fungal cell walls, including Chlamydia, Aspergillus, Saccharomyces, and Pneumocystis species. Results after injection of beta-glucan, SKG mice developed enthesitis, wrist, ankle, and sacroiliac joint arthritis, dactylitis, plantar fasciitis, vertebral inflammation, ileitis resembling Crohn's disease, and unilateral uveitis. Arthritis and spondylitis were T-cell and IL-23 dependent and were transferable to SHID recipients with CD4 positive T cells.